Welcome to episode 3, Early Modern Fat Grafting and the Liposuction Revolution, the 1960s and 1980s. I'm Dr. Whitfield, board certified plastic surgeon in Austin, Texas. And the purpose here in this episode is to examine how surgeons revisited fat transfer during the 60s and 70s and how the advent of liposuction in the 1980s enabled viable fat grafting techniques. So this is a really interesting time. So the fat transfer reemerged, and really, Dr. John Lewis Jr. discussed it in his 1965 paper in the Plastic and Reconstructive Surgery Journal, and he highlighted what could be done with fat transfer, and maybe probably highlighted more of its limitations at that time, which makes sense. Here's his paper, and you can see. I'll read the description here. A partial absence of the right breast and a defect of the chest wall and upper chest musculature involving the rib and pectoral muscles following augmentation and correction of the defect in this instance with fat. And so these are black and white, obviously from the 60s, and not easy to really view. But the point is, fat, no matter what you're trying to do, is never going to press out and give big profiles, but it's a good tool for volume addition, contour irregularities, really smoothing out a surface, helping with scarring. And so how do we get from the concerns Dr. Lewis had with, acquisition and take and getting the effect we want? So basically, this boils down to the development of a liposuction cannula. So a French surgeon, Dr. Illouz, basically comes up with the concept of a liposuction cannula. This gives birth to basically liposuction. Before that, there was a lot of, I would say, from a patient side, there was a lot of complications. In 1921, there's a recorded attempt at decreasing the ankle size of a dancer, which ultimately resulted in tissue necrosis and loss of tissue there. And so that technique was abandoned, of course. And then in the 60s and 70s, there's more of these techniques where you take curettages, which look like tiny ice cream scoopers, but they're sharp. And then you can scoop out the fat. Think of it like that. You can do it through small openings or a big incision. So these curettage methods could acquire fat, but in the acquisition of fat, they would disrupt the lymphatic tissue and cause drainage. They could cause bleeding and lead to a hematoma. They could hurt the blood supply going to the backside of the skin, if you want to think of it that way. And then the skin wouldn't heal well, it may blister, it may die. So all of those ultimately get abandoned because there's too many complications with them. So we need something safe and effective and reproducible. And that's where Dr. Illouz establishes himself really as the person who sets the stage for this by coming up with the blunt cannula, which, think of like it's a straw, but instead of the end being open, it's closed. And on the sides, the straw has openings. And that's basically a liposuction cannula. So he gets asked to take a shoulder lipoma out of somebody without leaving a large scar. Every plastic surgeon has been asked to, do things with minimal scarring, minimal downtime, minimal swelling. So he figures out how to do this using this cannula. And he also figures out that you have to instill fluid. So you make an opening, you put fluid in that expands the space with which you can work. And it also, depending on what you put into it, can diminish bleeding, can provide pain control. So that sets the stage for fat removal. So this is purely secondary to Dr. Illouz's development of the blunt cannula. Then, as we kind of follow his work and which is transformational, honestly, we go into the work of Fournier, another French surgeon, and how to acquire more semi-liquid adipose. While Dr. Illouz perfected the basic technique, it was Dr. Fournier who realized its potential for fat grafting. Because now we want to take not just fat out, we want to have it survive. We want to be able to put it back somewhere. So really Fournier makes it possible to obtain large amounts of semi-liquid adipose tissue. So the terms get coined, liposculpture for body contouring, and in 1983 he introduces the concept of syringe aspiration for low pressure harvest, and then Dr. Fournier wants to replace the mechanical pumps that were being used that probably have a little bit higher pressure to syringe, which are obviously lower pressure at that point. And then by manually withdrawing on the plunger, he felt he could create a more gentle vacuum. So I learned how to do this technique. This technique was taught to me both in training, and I practiced this way for a number of years. Um, Now, that's for taking, whether it's a small particle, something that's 3 or 4 millimeters, or even smaller than that based on the cannula size. But a syringe can only go up to 50 or 60 cc's. And if you're going to do small areas, like something that in 1985 was coined like micro lipo extraction or micro lipo injection, most commonly these types of techniques would be used at facial rejuvenation procedures and these small areas of treatment. You would harvest fat and then you would inject in these small areas, but it would be small aliquots or small amounts. Um, Dr. Fournier discussed doing it under different types of harvest conditions, including not adding fluid. So this technique allowed fat to be collected without the dilution associated with placement of tumescent solutions, which are the fluids we put in, and that gave you a higher concentration of fat. Now, you can't really get a large volume out that way, so we have to figure out how to get a large volume. So we have Dr. Illouz's blunt cannulas. We really have the collection, if you will, and the advent of using it for augmentation, really more of a concept Fournier talked about. And now, how we get to a larger volume acquisition is we have to put fluid in, and that's really Jeffrey Klein in 1987 makes it so we can allow larger volumes to be extracted without as much problem with bleeding. We can instill medications for control of bleeding, for control of discomfort, and that's really done based on the Klein irrigator, which has been in plastic surgery since 1987. I use it all the time still. Basically, that sets up fat grafting in what I think of like modern cosmetic breast surgery. So the ability to obtain a large volume of semi-liquid adipose really had immediate ramifications for the use of fat grafting in practice. And this was really an exciting, time, if you will. The thing that put the brakes on it, honestly, was concern over screening for breast cancer. So the taking a step back, we're going to look at why, if we understand screening and we're pausing just to learn more about screening, really face and buttocks grafting continue and move forward. So there's different techniques for those, and we'll just talk about the face, the Coleman technique, which everybody was taught during my era on training. Plastic surgeon Sidney Coleman out of New York really refined using liposuction for fat grafting, especially in the face. He used smaller cannulas to collect fat in 10 ml syringes. He used centrifugation and then would inject back into the recipient sites, predominantly in how I think of this. The Coleman technique was really, used not just for face but other areas, and that causes some problems with safety in other areas. But for the face, it definitely was an exceptional technique. The buttock, because it's such a large area, it didn't make as much sense, obviously, because think of on scale, if you put a few milliliters of fat in the face, you're going to notice it. But because the buttock is such a large area, you need 500 cc's per cheek or 800 cc's per cheek to make a visual change. And then for our breast, because it's a smaller space, although you need less, you still need a pretty good volume to make a visible change, depending on the patient and their skin stretch and your ability to transfer from their donor sites. So we're still trying to overcome in the cosmetic breast procedure. Is it going to be safe? And it gets tabled for a long time. Organized plastic surgery doesn't advocate for it. It's concerned about delaying cancer diagnosis, causing mammographic abnormalities. Ultimately, those don't get borne out, and it sets the stage for what we do today when we do cosmetic augmentation. And I always think of them, I mainly do breast, but breast and buttock, you know, it's just a volume, difference. So you're trying to acquire fat, transfer fat, put it in the correct space beneath the skin, above the muscle in the fatty layer. And there's depending on where you're on the body, there's different layers of fat. But mainly we're really concentrating on now setting the stage for modern cosmetic fat grafting to the breast. All right. I look forward to the next episode.